We've talked a little bit about the underutilization of anticoagulation in patients with AF, and one of the reasons is bleeding. That's an important topic. Therefore, let's talk about a paper that is in the March 11th issue of JACC, and it is factors associated with major bleeding events, and it's from Rocket AF. And the first author of this paper is with me, Shaun Goodman, who is Associate Head of Cardiology, St. Michael's Hospital, and Professor in the Department of Medicine at the University of Toronto. First off, let's talk about major bleeding and the Rocket AF trial. What did you find?
We found, first of all, I guess most importantly, that this more novel or direct target-acting anticoagulant rivaroxaban was as safe as warfarin, the previous gold standard, with respect to major bleeding. And then, in addition, what we wanted to look at was what are the factors that, in particular, are associated with major bleeding. Were there things at the beginning of the study that we might identify, certain patient characteristics, that might predict who would be at greater risk down the road to develop a major bleed?
Now, in this particular analysis, I mean, it's from Rocket AF, how many patients were you looking at, et cetera?
Sure. So Rocket AF was 14,600 and change patients with non-valvular atrial fibrillation. Obviously an international study with great contribution from North America. And this was a double-blind, double-dummy study where patients got pills, either the active rivaroxaban or the active warfarin, and or a warfarin-like equivalent. And so we examined those patients over the course of several years, made a comparison between the two. So I think we were in a pretty good position given all the number of bleeding events. For example, we had over 780 major bleeding events over the course of time to be able to try to look at some different models to predict major bleeding occurrence.
What about bleeding location?
Certainly an important point. So consistent with the other newer or novel oral anticoagulants relative to warfarin in other trials, we found that intracranial hemorrhage, one of the dreaded complications with respect to bleeding related to warfarin, was significantly lower in the rivaroxaban treated group. So even though the overall major bleeding rate was similar between the two treatment groups, it was actually significantly lower in terms of bleeding into the brain. The flip side was, and also again relatively consistent with the newer agents compared to warfarin, we did see a signal of increased bleeding with rivaroxaban in this case compared to warfarin, in particular in mucosal bleeding. So I would define mucosal most importantly as gastrointestinal bleeding, a little bit higher signal there, and other more nuisance-like bleeding like nosebleeds, bleeding in the urinary tract.
Is there a mechanism that might explain the significantly lower ischemic cerebral vascular events in this particular trial?
It's a great question. I'm not certainly an expert in that, but I did tap into the experts within our group and from working with some of the other compounds, and it's really speculation. But it appears probably two potential mechanisms are probably the front runners for explaining this. One would be that we know that warfarin is not a target-specific agent. It works on multiple factors in the clotting cascade, and so has a more diffuse effect, whereas these agents, either a direct thrombin inhibitor or, in the case of rivaroxaban, a 10A inhibitor, is very specific to the coagulation cascade in terms of interrupting that pathway. And so that's one speculation in terms of why warfarin might cause relatively more bleeding into the brain compared to, for example, rivaroxaban. The other relates to some of the characteristics. For example, there may be more tissue factor in the brain, and that again may have some relatively harmful effects when it's sort of bundled all over, covering different parts of the brain. When warfarin is, around compared to something like rivaroxaban. But again, speculation.
In terms of risk analysis, how did the approach you took differ from like Atria and has bled?
Well, we were originally quite interested in looking at those reasonably well-established and validated bleeding risk scores, and seeing if we could sort of, in our patient population, use them to identify those 780 or so patients with major bleeds in both the warfarin and the rivaroxaban treated group. When we did that, unfortunately, the performance of those two scores was really not as good as we had seen for example, in earlier versions of the original derivation of those scores or in other populations. Now, that's not necessarily saying that these are not good scores to use. And in fact, one message I would like people to come away with is I still think it's important to use a standard risk bleeding score to, in particular, to look at the modifiable factors that we might be able to help patients with to lower the risk of bleeding. But those two particular scores didn't perform, again, overly well. And it's probably because we're looking at a slightly different patient population, a little bit more selected. Any patients that come into a clinical trial are already pre-selected based on their inclusion and exclusion criteria, and that may account for some of the differences. It's not necessarily, again, that the scores are bad or that they shouldn't be used, but they just didn't perform as well as we might have hoped. So we looked at our own model, not with the intention of translating that to compete with the other models, but just to try to look at are there other factors besides those that one would look traditionally in the HAS-BLED score or the Atria score to try to predict major bleeding. And we found a lot of similarity, but some additional things that might not have come out in some of those other scores compared to the model that we looked at. The most recent ACC AHA guidelines, for example, that just came out, do number 1, number 2, number 3, I can't remember the exact order, but it's very high up there, use an estimate, certainly of risk stratification, first from a stroke and systemic embolism prevention perspective, but also, or in this case, CHAD's Vascular, most recently with the American guidelines. But I think bleeding risk scores are important to, again, identify, in particular, what might be modifiable. A lot of these things have similarity. Older age is a risk for stroke, but it's also a risk for bleeding. We probably can't do a whole lot about older age. In contrast, some of the things, for example, in HAS-BLED, the H in HAS-BLED represents uncontrolled hypertension. So can we modify somebody's blood pressure control, and that would likely lead to a reduction in major bleeding risk. Another example, again out of the HAS-BLED score, the use of certain drugs like aspirin. We saw even in our particular study, in the ROCKET-AF study, that having had prior use of aspirin was a predictor, increased risk for major bleeding. Does a patient, an elderly patient who is on stroke prevention therapy with an oral anticoagulant, do they really need an antiplatelet agent on top? In some cases they may, but I think we might be using aspirin, for example, maybe in a cavalier fashion in those patients, or forget that they had a previous diagnosis of coronary disease and that's why they were on aspirin, but now they've got atrial fibrillation and the stroke risk, we need to use an oral anticoagulant. So maybe we can, again, think about some of the modifiable risk factors, and rather than doing that off the top of our head, I think a systematic score, for example, a bleeding score, is probably going to win the day in terms of improving the quality of patient care.
I mean, we know that we need to get a few more patients on anticoagulation therapy. The numbers, according to the NCDR database, is lower than it probably should be, and we also have people who are low risk who are on anticoagulation,
right.
People who are high risk who are not. Bleeding is a major issue. What's
sure.
the bottom line message that you have?
Well, I think from this particular study and also from some observational studies that we and many others have been involved with, the primary care physicians who are making these treatment decisions tend to overestimate bleeding risk in many cases. And therefore, by using a systematic score, then maybe we would see, rather than just saying, oh, this patient's old, they're at a high risk for bleeding. That's not always the case. So if they use a systematic score, maybe they'll identify a more moderate risk of bleeding than they thought that they had come up with off the top of their head, and therefore maybe utilize more appropriately oral anticoagulation.
There have been studies where they just ask doctors what they think the risk of bleeding is, and sometimes they're tenfold off or more from what the actual data shows. So
absolutely.
It's an important topic.
Absolutely. I agree with you 100%.
So the topic here is major bleeding, and it comes from ROCKET-AF. Please go to the March 11th issue of JACC and read the paper for yourself. For Cardio Source World News, I'm Executive Editor Rick McGuire.